like Tom said, I work at Central District Health Department. I manage the Communicable Disease Control Program, which is all the people who do like disease investigations. Some of you may have been contacted by people that worked for me before, if you've ever been diagnosed with a disease that we care about. And there's about 60 of those that we monitor pretty regularly. And I also oversee our preparedness program, which helps us develop plans and train and exercise for public health emergencies like disease outbreaks, natural disasters that might impact public health like flooding or earthquake, things like that. So it looks like I'm up. So I'm going to go ahead and get started. Today we're talking about the essential services of public health, and we're just going to be focusing on a couple of them in the assessment area: monitoring health and diagnose and investigate, since those are kind of the areas that I work with most frequently. And it sounds like Tom has already explained some of this model to you. Basically, it's a process. It's cyclical, so you start in monitoring and doing diagnosing, investigating, and those pieces feed into policy development, decision making, and implementation or assuring public health. And obviously, threats are always changing in public health or continue to kind of persist, so we're constantly kind of monitoring that and providing input and information into it. So like I said, monitoring and diagnosing is what we're going to emphasize today, and that's really kind of the foundation for the whole essential services. Without this piece, you really can't go forward. So there's two basic pieces in monitoring health status that we look at, and that's assessment and surveillance. And I'm kind of just going to go through explaining these two essential services, and then I'm going to kind of switch gears and talk about the real reason Tom invited me here is to give the practical experience on how we take what's in this model and apply it to what we do on a day-to-day basis. So assessment and surveillance are something we do continuously in the area that I work in. So in assessment, we're looking at a lot of different factors. One is just identifying risk groups. And it depends on where you're studying, kind of. In my area, we look at infectious diseases primarily. So we look at risks that might affect certain populations. For example, we know influenza typically affects the elderly and the very young and the pregnant. Some diseases like coronavirus, which is spread by the little deer mouse we have around here, that can affect healthy individuals in their 20s. And so depending on what we're looking at identifying the risk groups. And what we do with that is looking for ways to identify and target them for education or some kind of intervention or prevention method. We also determine health status in assessment. So a lot of times we do surveys, we collect data on vital statistics, birth, death rates, causes of death, information like that, and I'll show you some examples later. We also try to link people to services. A lot of times there's services available to help people, but they don't necessarily know that they exist or how to link to them. And one example in Idaho is the 211 line, the care line, which some of you may have heard about. So we look at identifying those people who need assistance, and assistance is available, and linking them to those. Where we constantly are working with the essential services is where maybe we've identified issues, but we haven't found solutions or resources to link them to. So that's one piece that we are always trying to work on too. So with surveillance, with what I do in infectious diseases, I can give probably the best examples, but there's also chronic disease surveillance that occurs too. So for active surveillance, you basically have two types, active and passive. With active surveillance, you're looking at being more proactive. So something's happening now and you need to gather the information today, or people are going to die or be sick down the road and you want to prevent that. So outbreaks and epidemics are good examples of those. For example, with the H1N1 outbreak we had in 2009, we were calling the ERs on a daily basis, and they were providing us information on who was coming into the ER, what symptoms, and demographic information, just to make sure that the virus may be switching in certain affected different population. So that's an example of an outbreak epidemic. Special events too. So we don't have a whole lot of special events per se in Idaho, but I think it was in 2009 we had Special Olympics here. So we had people coming from all over the world coming here, and we know that there's other diseases in different parts of the world that we don't necessarily have here, but if they were introduced could cause a problem. So in that case we kind of switched into active surveillance mode. Even though we didn't have a problem with any kind of disease at the time, we knew that people coming in potentially could have diseases that could threaten the community. So we monitored those, and we're really careful about doing health checks when they arrived and having them actually done before they even came. But sometimes diseases don't present themselves until later, a few hours or a few days after the exposure occurs. So those are kind of examples of active surveillance. And with passive surveillance, that's kind of what we do on a day-to-day basis. And even if we're in active surveillance mode, we're still doing passive surveillance too, because there's plenty of work to do. We don't just drop everything and focus on the one disease that we're concerned about or this special event. So this is just kind of an example. Let's see if I can use my little dot here. And this is really, I know you can't read this, but this was the H1N1 flu, some of the flu data we had here in Idaho, and it has like different countries and their number of cases and kind of tracking it through time. So that's kind of an example. At the time it would have probably been considered probably not even active surveillance, because by the time someone goes to the emergency room, and this I'm not sure because we didn't actually create this table, but you can use ER visits, you could use lab reports if lab reports are available, clinical diagnosis from a physician, that's available. Even sometimes word of mouth, we kind of keep numbers on. For example, in 2006 we had a West Nile virus outbreak here, and so we had some that were lab confirmed, but the labs were really inundated, so they were not even able to test everybody that was symptomatic. So we would get some that would confirm out, some that the physicians would say classic symptoms of West Nile, and then some that where people would just call and say, I think I have West Nile. And eventually we started even just counting those too. We'd get their symptoms, if they were consistent, we'd mark them, because they just didn't have the resources in the community to test everybody, and some people didn't have the resources to go to the doctor. So unless they were like dying, they were just calling us to say, got these problems, what can I do, or just to let us know. Believe it or not, people like to call us and tell us about their diseases that they're having. Sometimes that's okay, sometimes it's a little weird, but so I kind of forgot where I was at. But on this, so on passive surveillance, sometimes you're kind of doing that at the same time you're doing active surveillance on different things. And this could be considered kind of both active and passive. I'd say it's hardly active. And the reason is that this is probably lab data. And so it's not really a true indication of what's happening at that moment in time. It's more like a week or so before, because someone's usually sick for a few days before they go to the doctor, and then the doctor orders the lab, and then the lab test goes to the lab and it comes back in 3 days, and then the physician gets around to reporting it to us a day or two later. So you're already like a week out from when the person was sick, and they were probably sick for a couple days before that. So it's not really timely information. When we're trying to do active surveillance, we want to know as soon as possible. And that obviously, they generally have symptoms, but sometimes we identify people who are sick, and then if it's like a contagious disease, we're trying to find out anybody else that was exposed. So we may even identify people that aren't sick today, but are going to be sick in a couple days. And I'm going to talk about that later. I'm kind of getting ahead of myself, but those are kind of the differences between active and passive. And if you guys have questions or you have anything you want to add, feel free. Sometimes we have, when I'm teaching this, I have students who've had these diseases or know somebody who does, and they have an interesting story about it, so feel free to share. So that was monitoring, which was, again, surveillance and assessment type stuff. So in the service number 2, looking at diagnose and investigate, we look at the health problems and health hazards in the community. And I'm not going to talk too much about health hazards. Generally, those are more injury or environmental type issues, and I know Tom can give you plenty of information about those things, being an environmental type person. So in epidemiological investigations, we're talking about, and just to step back, so epidemiology basically means the study of diseases in human populations. I should have said that probably before, but I know that not everybody knows what that means probably. And it can apply to anything. So in my background education, it's primarily infectious diseases, but also like chronic disease, environmental associated diseases, injuries, chronic conditions, if I didn't say that, genetics, molecular disorders. So it's a very broad field. But in this context, we're talking about case investigations, and I just started to talk about this on the last slide. So one thing we do is we have this list of like 60 diseases in Idaho, and it kind of varies by state, but in Idaho we have about 60 that we monitor, basically. And if we have a disease that pops up, say E. coli, that's one we get quite a bit this time of year, we contact the person or the parent or guardian of the case, is what we call them, and kind of investigate. It's almost like a crime investigation, except they didn't commit a crime. So we are trying to gather information about where they might have been exposed to E. coli, if anybody else has had similar symptoms, where they've been, what they've eaten, those types of things, because what we're really trying to identify is the source, which is kind of the next bullet on here, contact and source tracing, because this is a communicable disease that can have life-threatening consequences, especially for young people or people that are immunocompromised. So, for example, this summer we've had quite a few E. coli cases associated with recreational water, hanging out in kind of like ponds or lakes and shallow waters where E. coli seems to do well in the warm temperatures. And so we identify these sources, and then we take measures to try and prevent that spread. So we worked with DEQ to Department of Environmental Quality to take water samples to see if the water tested out with E. coli, to see if that was indeed the source. Yep, it was the source. So then we post signs, or DEQ posts signs to warn people not to drink the water. It tends to be children, so you don't see a lot of adults sitting over the coffee cup drinking the water, but kids like to play in it and drink it. And then part of the reason we do this is for identification of outbreaks. It's not the sole purpose. I mean, any way we can contain disease spread from occurring, that's what our goal is. But early identification, or really trying to prevent disease outbreaks from occurring, are really what we are focusing on. So if we didn't do anything about the dirty water at Lake Cascade, for example, and people just continued to go there for the next 3 weeks, we'd see a lot more E. coli cases probably, especially in the little kids who like to drink the water. But so hopefully what we did made a difference. And then active infectious disease epidemiology. So there's kind of a difference, and people call them different things. I just call the epidemiological investigations because they're really investigating what's happening in the community or with individuals. And then there's just what I'd take out investigation out of, and it's just epidemiology, and that's really more research-based. But that ties in because you're taking the people who are doing the case investigations, you're pulling that data out and looking at it if it actually means anything. And a lot of times the people who are doing the investigations have a pretty good sense, because they've been doing it for a while, on, man, you know, I only had like 1 E. coli case for like a week for the last 3 weeks, and now all of a sudden today I got 5. And so it's like kind of intuitively, a lot of times they can say, I see a problem or a threat happening. But sometimes if trends are occurring at a slower rate, you may not really recognize that there's actually a change. So we monitor our data over time to see if we have something that's emerging, whether it's a new disease or just an increase in incidence for some reason, and we just haven't identified the source yet or really found it as a problem. And then just monitoring disease trends. One good example is chlamydia. no matter what, it's the leading disease we have by almost 1,000 every year. So whatever we have, it just is just straight like this. Well, I shouldn't say it's like that. It's like this. I don't know if that's just population growth, but there's problems with chlamydia, just so you all know. And then public health labs, so that falls into diagnosing and investigating too. And we work really closely with especially our state lab, but we also have other labs in our area, hospital labs and public or private labs that take samples from doctors' offices and hospitals. So they kind of feed into this, and one, the diagnosing piece obviously, because physicians are collecting samples or we are collecting some samples and we're sending them off to the lab to get results back. So we're monitoring those and really relying on them to give us timely and accurate information. But they also sometimes will help us, believe it or not, with like investigations. If we're like not connecting dots on something, sometimes they'll catch it. And especially if we're doing like PCRs or molecular testing, because it's almost like a fingerprint. You can match certain strains of bacteria, for example, together and maybe get like a water sample and then test that and do like a molecular fingerprint on that and say, yep, that is definitely linked to those. And yes. Yep. Mm-hmm. Yep, that's exactly what I'm talking about. So an example of that we had recently here, and it's not in the news or anything, but is E. coli again. But someone had bought a beef, and I think people just do that more these days. So they bought a cow off of local farmer or rancher, and they I think processed it on site. They got the beef, and then they, made hamburgers for their family. Well, they probably didn't cook the meat enough, or they left it out, and anyways, so E. coli started to grow. Bacteria grows, if you leave meat out for too long or it gets temperature abused. So didn't cook the meat all the way. Family got E. coli. They took samples from the meat that they had and their biological samples that they had from the lab and matched those. So the family could say, yep, definitively the meat that we bought at this farm or ranch was the meat that made us, or the food item that made us sick. Because it could be almost anything, and especially if you eat out quite a bit, then your risks for exposures tend to increase. So they were able to do that, and that's good. So from a public health and epidemiological point, because you've like closed the case, you know what the source was, and done deal, you can contain it and all that. Now there's a whole other side of that we kind of have conflict with, and that's the whole legal issues that seem to arise out of those these days, and lawsuits, and in some ways those are good because they can end in policies and laws to help prevent this from happening. At the same time, they can be very expensive for some people. And then environmental health feeds into that too, and some of the examples I gave kind of show that with the water samples. They play into diagnosing and investigating when you're talking about food or water contamination. So, diagnosing, I also talked about this a little bit, so this is really an important element. And in Idaho, it is state law that if a provider basically clinically diagnoses or gets a confirmation from a lab test of a reportable disease, they're required to report that to us. That maybe happens like 90% or 80%. Maybe it doesn't happen 80% of the time. We hardly ever, labs are great. Physicians don't, they probably don't have the resources as part of the reason. And a lot of times I think they don't really know. They don't learn in medical school that they're supposed to really work with public health very well. So there's a kind of a gap there. But in some cases they end up working with us very closely, especially if it's a disease that they don't have a lot of knowledge about, then they really tend to lean on us. So again, the laboratory piece and state lab capacity, that's something that's changed over time, but fortunately we've been able to kind of make it with what we have. And I don't know why I have state lab capacity and public labs right into that. I guess maybe it's supposed to be private labs, but we get, again, these examples of the physician and then the lab testing occurring, and really it should be probably public health on this side or that side, and kind of like a circle of thing. But It doesn't always happen that way, but that's diagnosing. And investigating, I did talk about this quite a bit already, but determining the sources of the disease is one of our primary goals, and the reason is that we really want to prevent disease spread from occurring in our community. Two different things that we kind of worry about. One is contagious diseases, others non-contagious. Most of the diseases we deal with are obviously contagious because they spread quite a bit. So that basically means they're spreading from person to person or animal to person. And so we're identifying risks in the community and trying to minimize those. Non-contagious type diseases might be like anthrax, for example. It's not contagious from like person to person, but if you got into it, it'd make you sick. Same with, well, hantavirus is zoonotic, but these are my little images down here. So y'all know sushi's bad, right? I eat a lot of sushi, but I stopped saying that. Gotta live on the edge once in a while. So don't eat too much, but. That is somebody, I think it's a sneeze, and that's what it looks like, you know, when someone lets a good one and they don't cover it up. So if you're ever at the grocery store on an airplane and someone does that, you know, I'm sure you've all been there. It's kind of gross. Here's the environmental hazard right here, with people walking in very dirty water, I'm sure. That might have been taken from Katrina. Mosquitoes. We don't have a lot of mosquito-borne disease here. We had our bad year with West Nile virus, and that still persists, but not nearly as bad. We have a couple other mosquito-borne diseases, but I'd say West Nile is still probably our most prevalent one. My angry dog here, he's supposed to represent rabies. You guys know how rabies spread? No? A bite from a rabid animal. So does anybody know, is there a cure for rabies? How many people die? I mean, like, if you get rabies, what's your likelihood of dying? It's pretty low. So, believe it or not, one of the people that works in the health department with me, her grandchild just, they found a bat in, he's only 2 months old, in his room. And the dad captured the bat and then released it out into the wild. And that's not the right thing to do, by the way. So if you find a bat in your house, you can capture it, but then call us, and we'll take it to the lab to have it tested, because rabies is pretty prevalent in our bat population. And if you don't, a lot of times people don't know they've been bit. So if you do get one, you want to have it tested, and we could take off its head and send it over to the lab for testing. And if not, it's true. And if it's your dog, you know, make sure you get your dog vaccinated, because we don't have to take his head off. That's the only way they can test it. There's no like blood test for rabies in animals or humans. Once you start getting symptoms, you're kind of done for. So, and if you don't have the animal, then your ER visits are going to be like $1,800, and you need 6 of them to get what you need to not get rabies. So it's very expensive. And I don't know if insurance really covers that. It seems like they would, because life insurance policy is probably more expensive. But we have issues with that every year. So stay away from the bats and get your dogs vaccinated. We don't have a lot of rabies in dogs, though, or cats. This is primarily bats around here. Crowded places like this can be good places for disease spread. Of course, that's outdoors, so it's a little less, because then you got some open air stuff, but you're still having direct contact with a lot of people, and more direct contact. And this is more of an environmental type picture, I'd say. There's actually like a city in there somewhere, but dirty air, so. All right, so this is the part where we kind of transition into putting knowledge into practice. So I already introduced myself, you know where I work, and you kind of know what I do. So we're going to talk about those 2 first essential services and how they're incorporated into what we do on a daily basis. I'm just going to look at my notes really quick to make sure I haven't left anything major out. Okay. So, do you guys have any questions at this point? All right. Oh, yep. No, the risk of someone, well, we really assess every situation very carefully, but the risk of dying if you're exposed is almost 100%. So if you're not sure if you were exposed, usually we play it safe. For the example, this baby was only left alone for a couple minutes without a parent that was awake during the whole time, but they didn't know the bat was in the room until they came back in, and the lights were off. So there's a chance that the bat could have been on the baby and for a minute or two. It's unlikely, but would you risk the life of your 2-month-old? And so, unfortunately, they had, fortunately and unfortunately, they made the decision to provide the vaccine and the immunoglobulin, which is what they use if there's been a bite, to the baby, but it's really expensive, and really the only people that hold it are the ER. So every visit, and you have to get I think it went down to 5 shots now. It used to be 6. So every visit's really expensive. Yeah. Get that? Yeah. Mhm. Yeah. Yeah, that was 8-10 years ago maybe. That girl in Minnesota. Yeah, and yeah, they've never been able to repeat that treatment and have it be successful. And I think the child was 9 at the time, and they've tried it in a couple people that 15, 17, I think. But yeah.
I used to get, when I was first in the health department, the CDC would send out photos of moving pictures of people dying.
Yep, I saw. No, I know. I saw him too when I was in the military, actually. But yeah, I think they kind of put you in a coma now, so nobody has to see that. You have all that, be drooling and out of it, yeah. Uh-huh. There's no vaccine for humans that's effective. Yeah, and actually I shouldn't say that because veterinarians get it. Yeah.
You go, so you're traveling CDC,
yeah.
Trying to stay in the country, they'll tell you to get.
Yeah, that's right.
Take the shot before you go.
Yeah. You get the whole series, then you have to have an annual booster, right?
Yeah.
So it's expensive. Right. And then you have to have the booster, but it's expensive, so unless you're going to be at an area where you're likely to be exposed, then they don't recommend it. Because just, here on a daily basis, we don't live in filth or where there's a lot of animals that don't belong to owners and that aren't vaccinated. So I think that's kind of the reason we don't.
The problem I always had around here is the dog bites somebody and pull out a gun, boom, the dog in the head.
Yeah.
Well, then you can't look at the brain. You got to dissect the brain and the body and the brain. So,
yeah, that's good. Parents do that too, and neighbors. I've seen that happen where the owners of the pet, they bites their kid and then they're ticked and they go out and shoot their dog in the head. Bat, yeah. Dog's head or bat's head, yeah.
Catch it, put it free.
Yeah. And you don't have to take the head off. We can do that for you, so I feel like you need to do that. Yeah. Actually, we have 4 of them sitting up in our health department right now. People got into some bats this weekend, apparently. So. All right. So I kind of talked about these already, but this is just at a program level of what we do So we do the infectious disease epidemiology, which is kind of the research side. I mean, it's not like heavy-duty published research, but we're looking at the data and we're following disease trends and looking at where we need to put our resources because they are fairly limited. And then the investigation and surveillance, and that's probably where we spend the majority of our time, is just talking to people who've been sick with various diseases, collecting information from them, trying to educate them about how not to get reinfected with some diseases or how not to spread them to others. When there's people that are sick with some diseases like E. coli or salmonella and say they work like in a daycare center or a food facility, somewhere where we are really nervous about them maybe exposing others, we do make them stay home until they're pretty much cured of their infection. And by make them, I mean we ask them and politely. And most of the time. I mean, there's some cases where we do have to force them to do certain things. But and then community assessment, and I'll talk about that here, and I think maybe the next slide or two, and how we do that in our department. And tuberculosis control. Do you guys know what tuberculosis is? Yeah? I always refer back to the Tombstone, the movie. Doc Holliday had TB. Yep. So we actually have that here. So a lot of people think that's a disease that doesn't happen anymore, but it does. And so we're very active in monitoring and controlling that. So, okay. Oh, there's more. So the other job that I do right now, but I'm not going to be doing for much longer, is public health preparedness, and I talked a little bit about that with our role in emergency responses and training and educating our staff and working with community partners. So we have department level planning that occurs, and it's pretty broad spectrum so that we can kind of handle any kind of hazard that might affect public health. We do have some specific plans for certain types of events, but for the most part, they're pretty broad. And the training, so we do primarily that's just our staff training, and we do have a reserve medical corps that's about 300 strong right now. So they also receive training from us and help us out quite a bit. And we exercise those plans that we develop. So we might develop a plan, for example, on distributing vaccine or medications to the community. So you have like a hepatitis A outbreak, and the person that was diagnosed was a food service worker, and now we have like 5,000 people exposed. We want to make sure those people have the resources. If they don't have the resources to go to their doctor, they can come to us. So we might exercise how we would make that happen, because that's not something we do on a day-to-day basis, but when we do need to do it, we want it to happen smoothly and make sure the people that we're trying to protect are able to access the resources from us easily. We also do a lot of regional planning. So the district that I work in covers Ada, Boise, Elmore, and Valley counties. And so we work with local emergency managers and hospitals and clinics, pharmacies, people who work with special needs populations, like the blind or disabled, homebound. Those populations, we work with them pretty closely in our planning efforts so that all those people can pretty much have access to what they need when they need it, and that we know what their needs are and what they're counting on us to deliver. Sometimes those don't line up. They might be like, yeah, go grab us like 100,000 masks that you have in storage or something, and be like, we don't have 100,000 masks. So sometimes that communication is really important. So they know what our abilities are and then can ask reasonable things of us. And then support for real world responses. Right now there's a staff of about 3 or 4 people that work in our emergency preparedness group, and they help us with developing the plans, updating the plans, and in an event they fit into different pieces. We have a person that's a liaison between the different entities that we're working with to respond. Another person's usually handling the medical, our Reserve Corps volunteers, and scheduling people to work, things like that, because when we're in a mode of a response, a lot of things kind of shift, priorities are different. So people who usually supervise certain people may not be supervising them, they might be answering to somebody else, and things like that. So this is us getting into the examples of that I'm going to go over, where we're tying all this now into what we do on a day-to-day basis. So for the assessment piece, or monitoring piece, this is an example of an assessment that we did, and we actually did this with BSU, this group right here. So we did a market demand assessment, basically, to see, our basic questions were, are we providing the right services for the community, and are we located in a position, a physical location that is pretty easily accessible to most people in Ada County. So we collected and analyzed data that we had from the health department, from birth certificate data, WIC, which is the Women, Infants, and Children program, Region 4 Health and Welfare. They have an office on Fairview. So we collected, we did some surveying there, and we did a lot of door-to-door surveys. We actually had BSU grad students that helped us with that piece, and we collected data from the U.S. Census. And once we got that compiled, we had some analysis done on that, and including some GIS work done. And so our results were, we had 776 surveys completed, and the conclusions were that we were pretty centrally located in the health, in Ada County where we were, but ideally we would be, especially with the growth that's occurred, we'd better serve the community if we had an office in Meridian and an office in where the old site was, Glenwood, right? State?
Actually, Orchard and Fairview.
Yeah.
Where the DQ building is now, Department of Environmental
Yeah.
Quality building is. I don't know what
Broadcasting?
education,
Or-
the TV, public TV.
Yeah.
That's where we started out in 1970.
Yep. So those were actually, it's kind of funny because we're not in that location anymore, but I said, oh, that's like a perfect location. So just based on the needs of the community and looking at socioeconomic status and what resources people needed that we provided, things like that. So that was an example of an assessment that we've used, and we're actually considering satellite offices again, or multiple locations. So that was done in '07, and it was useful information at the time, and we kind of sat back because we've been going through a lot of changes, and programs have changed quite a bit, and now we're like reassessing that and like considering kind of following what our survey showed us. So it'll be interesting to see if that happens. But this is an assessment that my office does on an annual basis, and this is our 2010 one. Our 2011 one's still being worked on, and this is just an example. So it's like our cover page here. Oh, where do I go back? Oh,
Push the top little button.
actually I need to go forward. There we go. Okay. So this is our little cover page, and then this is just an example out of the assessment on a page that we had. So I know you can't probably read this, but we have like the year the data was provided, not necessarily collected, because some of these data things are like 2 years old. But and then this is specific to Ada County. Because we work for 4 different counties, we have county commissioners that work on our Board of Health, and they pretty much dictate the direction that we go in, and so a lot of times they're interested in really their county, what's happening there. So we give a broad picture, but then we also narrow it down. So for this is Ada County, and then we have their rates, compared to what's going on in the rest of Idaho, and then the trends that are occurring. So is this increasing or decreasing or no change? And then if there is a change, is it better or worse? And then what the period is of the trend that we're looking at. And if there is a Healthy People 2010 at the time objective, we have that in there just so we have another measure. And I don't know how much you know about Healthy People 2010 and now 2020 objectives, but they're pretty much national standards of where we want to be in our, with our healthy communities. So in this case, for example, on this slide I have the percent of adults 65 years or older who had an influenza shot in the past 12 months. And in Ada County it was 80.2, in the whole state it was 68.4, and the national objective is 90%. So you can kind of see. And then that helps because our board members aren't generally, well, there's a couple health people, but most of them are just county commissioners. So you can't, if you just like gave them this piece of information, it wouldn't necessarily mean a lot to them. So to have something to compare it to is really good. So in this next year we have the Healthy People 2020 objectives, but we're also including, there's health rankings data out now too, and they also have a set of standards, which weird is actually different than the 2020 objectives. So it's actually maybe a little bit more like, here, try to reach this and then try to reach that, because for some states, you know, so for some states, this 90% may be like, it just seems like, why even try? We're never going to get there. So they might have, the health rankings might have it down at like 50 or something, I don't know. But so that I think people sometimes feel progress and it kind of gives them motivation to do better. And I think that might be their rationale, but I really don't know. So, but that's an example of a health assessment, and do that every year. Okay, so those are kind of the monitoring pieces, examples of monitoring pieces. Now this is like the stuff that I kind of like to talk about and most people like to hear about. This is like the disease stuff. So, and some of these are older, but they're good examples of investigating and diagnosing. So we have a tuberculosis outbreak, and if you read down here somewhere, this is actually done, I don't know, maybe this graph was done somewhere in Washington, and it says 94 to 06. So one thing about tuberculosis is that once you're exposed to the disease, it can take a couple years for you to develop. Usually most people, if they're going to develop an infection from their tuberculosis exposure, it takes about 2 years, 2.5 years. Some people, they won't actually develop active disease until they're like in their 80s and immunosuppressed, even though they were maybe exposed in their 20s. So it's a really kind of a weird disease that way. And some people will never get sick from their exposure for whatever reason. So that's why this date is so long. And this outbreak actually started, and this is supposed to be Seattle, I think, so it's kind of geographically not in the right location. But I didn't make it, so you can't blame me. So we had this outbreak here, and this is occurring among homeless shelters, which makes sense. People are all sleeping in these big areas and close to each other, and maybe not really going to the doctor very often and getting tested for things like tuberculosis. So it starts here, and then I'm not sure when this, I think, happened before us. It's Montana, obviously, and here's some in Oregon that happened. And this doesn't look really big. It actually should be a little bigger, I think, like maybe 8 or 9 little dots. But that is Boise. And so these are all on here because they're actually connected, even though the lines maybe don't tell it all. But these are all actually connected, and we know that from our laboratory resources. They did that genetic fingerprinting that I was telling you about, so they could tell that all these people at some point were exposed to the same person or persons. The same strain of tuberculosis was circulating in this group. So the surveillance piece, this probably wouldn't have been found if we weren't doing surveillance, and the laboratory piece. So those two pieces kind of going together showed us this, because when you're looking at something over a long period of time, like I said, sometimes you're not going to pick it up. I mean, you're like, oh, another homeless person. And really the only reason we found out or started investigating more is that we had 5 or 6 cases just pop up within a 2-year period in our homeless population, which, it's not a lot, but for our area it is. And so that got us concerned about it. So looking at health status, the majority of these people, actually I could probably say all of them, had either a mental health issue, I should say or a substance abuse issue. And a lot of times they end up having both. And so their access to care is very limited, medical care. And prior to this, and hopefully they still do it, but they instituted tuberculosis screening at the homeless shelters, I think maybe monthly or something like that. And I don't know if they still do it, but they used to, which was great, so that they could pick those people up. And then there are a few homeless or medical clinics that'll see homeless down in Boise that they can get them the treatment. But part of the issue when you have substance abuse is that your liver doesn't function very well, and so the medications that you take for like tuberculosis, for example, aren't really all that effective. So nor are they usually that compliant because they're alcoholics and they're not thinking about medication, they're thinking about alcohol. Yep. Yeah, and that's actually what we do. In these cases where people are infectious, and I have this right here, directly observed therapy and incentives and enablers, each of these people that we had that were homeless, except for the guy that fell off the overpass and broke his leg and arm, maybe both legs, we put them up in a hotel, and we take them their medication every day for 9 months or 6 months. It's generally 6 months, but it can go longer depending on what's going on with them. So that's like how serious we are about ensuring they get treatment. And in some cases, we've had one person that falls in this group who's now we've had to treat twice. Even though we did the directly observed therapy with him, his liver was so damaged that it really wasn't all that effective, so he got sick again. And he really had issues with complying and staying where he was at, so we put him in jail. And the jail administered the medication every day until he was done. So that's not normal practice for us, so don't be afraid we're going to throw you in jail. But we're that serious about protecting people from this particular disease, and that's how we handle it if we need to. But in the 5 years I've been here, we've only had to do that twice, and it was the same person, maybe 3 times. So, yeah. It's an airborne disease, so that's part of the reason why people are so concerned about it, because if someone like coughs or sneezes, or even if you're talking to them but just in close proximity, if they have tuberculosis, you know, you can't like feel it, but you have little particles of air coming out and spit, and the little tuberculosis, if you're sick, will ride on that, and the other person will inhale it. And once it's inhaled into the lungs, then you can develop this infectious tuberculosis. Uh-huh. Yeah. Big hood. Yeah, that's a little excessive. We don't do that. We don't come up to people's hotel rooms in their houses. Neighbors kind of freak out when they see that. But yes, that is effective in protecting you. But we do try to be discreet about it. So when we are taking people their medication, we don't, you know, put the mask on in the car and walk to their house. We usually carry it in a pocket, and right before we get to the door, we'll put it on. And so some people think it's kind of cool, and then they like show their neighbors, and they're like, "Look, the health department." But most people aren't that way. So that's. So directly observed therapy we do for the tuberculosis piece, and then we haven't really done that for other diseases. And then just while we're on public health authorities, oh gosh, I keep doing that. I'll explain just a couple more that we have, because I don't talk about it anywhere else, and it's kind of interesting. So we have the ability to isolate people, which is what we do when we put them in a hotel. If they're like homeless and they don't have the resources and we're worried about them taking off or exposing other people. We can isolate them in their homes. If a lot of times their family, they either live alone or their other family members have already been exposed. So we'll just leave them where they're at unless there's a risk to like a pregnant woman or something like that we might have concern about. So we have that authority, and then we have the authority to quarantine, and that basically means that we can for example, say some crazy student decided to make anthrax and come in here and like put it on the desk. We could quarantine this building, and basically everybody that's in the building is stuck in the building at the time, and everybody outside the building can't come in the building. So and that can apply to a building or a public park or anything that's a physical type structure or piece of land. So we wouldn't like quarantine people forever, but once we had like means to decontaminate people as they left the building and things like that, we could do that. So.
So when you're creating a budget for surveillance for the year, is it just a flexible number that, because you don't know if you're going to have an outbreak, or you don't know if you have to put a guy in a hotel for, is it just a number, then you request an extra dollar amount from the state if something serious happens?
Yeah. How that works is we basically just estimate, because we have a certain number of disease that we kind of expect every year to happen. So we estimate based on that. If for some reason it's exceeded, which for example, we had a person who came with extensively drug-resistant tuberculosis in our area, and her treatment was like $3,000 a month. So, and she was going to take it for like 2 years. Luckily, she moved back to Russia, but anyway, she was here at the time, and so that was going to put a strain on our budget. That's way exceeds what we would anticipate on treating somebody with tuberculosis for. So in that case, we have an emergency fund, which could help, or there's also like county emergency money basically available. So, and if that was exceeded, I mean, this is a single case, so you wouldn't really see that, but if it was like a public health emergency, then you could do like emergency declarations and things like that to get more money. Fortunately, those don't happen very often, but on occasion. So I talked briefly about quarantine, and that's about as exciting as that gets. I don't think we've ever used that authority. And then another one that we have used, but we don't use it very often, is report for examination. And this, I think, the initial intent when I first developed this, I think, was for people who have sexually transmitted diseases and don't want to get them treated or don't think they have it. And we could give them that order so they'd come to the health department to get tested and or treated. But we don't really use that anymore, which sometimes I wish we still did, because there's a lot of it. But we do use it for tuberculosis sometimes. So we may have the isolation order, but once they're not infectious, which is usually about a month or two after treatment, we still need them to finish the 6-month course of treatment. But judges don't like to make people be isolated where they can't go to work and they can't go to church and they can't go grocery shopping and all those things that are, people value in their life. So if they're not compliant, but they don't need to be in isolation anymore because they're not really a risk to people at this point in time, then we'll do the report for exam. And either it means we're meeting them at their home to give it, or they're coming to us, or whatever, but they have a set schedule that they have to follow, and it's signed by a judge, and they have to follow it. And that's only for people that we're worried about not being compliant, or they have a history of not being compliant. So. 4:45, is that how long? Or 4:30? 4:30. All right, 20 minutes. Thanks. I knew you guys would have it right. All right. All right, so I'm trying to think. Oh, I might go through this one kind of fast. Were all of you guys here in 2006, or kind of around when West Nile was crazy? We had aerial spraying going on and everything. I think we had just over 1,000 cases in the state of Idaho. And I think in our health district we had like 5 deaths associated with West Nile virus. So the virus itself, you get it from an infected mosquito. The mosquito gets it from taking a blood meal from a bird. Only the females transmit West Nile, and same with all other mosquito-borne diseases, because they're the ones that suck blood. And most people, like 80% or more, don't even have symptoms of West Nile virus. They never know they had it. But for less than 5% have symptoms, and I think even less than that, like 1% have what we call neuroinvasive disease. So it affects the spinal cord or brain, and you get swelling in those areas, and that's what people die from. And most of the folks that died in 2006 were elderly folks. They tend to suffer more, but after the outbreak we had in 2006, we did a research project with the University of Pittsburgh, and we drew blood on I don't know, maybe 60 or 100 some people that were infected with West Nile to later look at like the long-term effects of the virus, and the majority of those people were probably 20 to 60 years old, and a lot in their 30s and 40s and 50s. And it was really interesting, although they weren't sick enough to be hospitalized, or they say they were hospitalized, but some of them were out of work for like 6 weeks. They were super fatigued, really bad body aches. Some of them would get like polio-like symptoms, which I know most of you probably don't know what polio is because we haven't had it here in a long time because we have a great vaccine. But you have basically your limbs are not functioning the way they're supposed to be, and you have a hard time walking. And a lot of the people that, well, I shouldn't say a lot, some of the people that we drew blood on had a hard time getting their mobility back. They had to learn how to walk again and drive a car and things like that. So it's I mean, I'm sure you guys have all had a mosquito bite and you think, smash, blood, mosquito, gross. And you think that little thing's going to like disable you. It's just amazing. It's scary. So health status. Health status really doesn't affect West Nile virus so much. Like I said, elderly people tend to have more adverse problems. I think we also had some women that were pregnant and developed West Nile, and I know they were in a separate study with the CDC, and I don't know that I actually heard any results on how that went, but that's always a concern when you have somebody that's pregnant. And surveillance, so we do, and I talk about it on the next slide, but we have kind of two different types of surveillance here. We have human surveillance, and then we have mosquito surveillance. So in the human surveillance, we're looking at the disease occurrence in people, and you know, what's being reported through physicians or labs, and then we have what's being what's occurring in the mosquito population. So in like Ada County and Gem County and Elmore County, we have people that go out and trap mosquitoes every week. At their trap location, they take those mosquitoes, they get ground up into like what they call a mosquito pool, just a bunch of dead mosquitoes ground up into a little thing, and then they test those to see if they're positive for West Nile virus. So that's happening right now because it's that time of year, and then those results are sent from the lab back to either the mosquito abatement district, or in Elmore County we have an agreement between their abatement district and the health department where the results come to us, and we kind of work collaboratively on that. And communication is really important. People need to know that there's a problem out there. If they don't, then you know they're at risk. So that was really big in 2006, was letting people know, and I'm sure you guys probably heard a lot more than you ever wanted to about West Nile virus and what the risk was and how to prevent it. One environmental measure that we take is environmental. So when we get those mosquito pools in, say we do get a positive, and say it's like at the golf course in Mountain Home or something, then we report that to the abatement district, and they go out there and they do some kind of chemical or biological control to try and get the mosquito population back down, so at least the risk is minimized to the people that are out on the golf course, for example. Laboratory capacity, again, here is important, just to have the ability to test both mosquitoes and human samples. In 2006, as I indicated earlier, our lab got inundated, and when they weren't able to test every sample, some samples were taking like 2 weeks to get back, which was kind of pointless if you're a physician trying to figure out how to treat somebody. So when we have outbreaks, that's one issue that we always have, is the supplies for collecting samples and then the lab capacity to support it. And then research, I talked about that already. And this is just the vector-borne disease surveillance that I talked about. And so we don't do a whole lot of this at the department I work at, but my previous job, we did like mosquito surveillance, we did plague surveillance, so we'd go out and capture ground squirrels and stuff like that and get fleas off of them, test them for plague, just to see what's circulating out there, how much. We also did the same with hantavirus. That was like the coolest study I ever did. We went and captured deer mice, and then we got to suck the blood out of their heart with a syringe. And we had to wear one of those full suits that you were talking about because, you know, it's a problem. Really bad disease, if you get it. But sounds pretty inhumane, but it's really good research to know what the risk is in the area, because that's a disease that's very devastating too. So I already talked about the collaborative effort we have with Elmore County, and this is actually a couple of our trappers. This guy, obviously this isn't West Nile season because notice there's no leaves on the trees. So he did this, I think, in the fall or something, just for a picture for me. So, but that's what a mosquito trap looks like. So if you see one of those out, don't mess with it, please. And once they capture all those, you get like all kinds of bugs in there, and you get male mosquitoes, which, like I said, we don't care about. So they go through and they look at every bug, and then they make sure they get the ones that we actually care about that carry the disease. So sometimes they have like over 1,000 bugs they have to sort. I talked about identifying that and integrated pest management, and that's just us kind of working health and abatement districts kind of working together to make good decisions that help protect the public's health. Yeah.
Did surveillance start after 2006?
No, it started after 2006. In Elmore County, and the way it works in Idaho is that they had to vote to get an abatement district. It had to be like a citizen vote, or I don't know what the technical word is for that.
Years ago, mosquito district in Elmore County.
Mm-hmm.
And then the problem is, once it's established, it takes like 2 years, and it's going tax roll.
Right.
So if you've got a problem, you voted in today, it takes 2 years before you spray mosquitoes.
Yeah, and it did. Although what we did is that basically public health did the job for the years before the abatement district was established. So they paid us to do the work in Elmore County. And I think Ada County already had one. Gem County had, actually they had theirs voted in too, I think.
Yeah, well, Ada County started in the early 70s.
Yeah,
Mosquito abatement.
right. But Gem County, I think, was added later.
After that.
Yeah. So some counties don't have them because they're so small they can't really afford them. So if they have an issue, then we can usually try to help them, in like we did with Elmore County.
And they changed the Idaho code so they can rank them.
Mm-hmm.
Right now, we need to do something.
Right. And I think we had some county emergency declarations so that we could do aerial spraying because that was really expensive. But we actually, I don't have it here, but I have some slides that are pretty, and it's always hard to know 100% what makes diseases go down as far as, you know, the incidence. But we have like this West Nile virus cases kind of going like this, and then we have like, okay, we sprayed here and we sprayed here, and then you see this. You know, and some of that's time too, because you get into the fall and winter, or fall and temperatures start cooling down, and the mosquito populations start dying down, and so disease starts dropping off too. But certainly the sprays probably could have been more beneficial if they'd been earlier. But that's the way emergencies are a lot of times. You know, it's not you don't do anything until it is an emergency, and then it takes time to like deal with it. So, but it probably did help. I'm sure it prevented some people from having exposures. But earlier would have been better. This was a really great outbreak too. So this is cryptosporidiosis. Is anybody involved in this? Because like, I don't know, thousands of people probably got sick. We only know about 200 of them, but the way it works, I'll just tell you. So with cryptosporidiosis, it's caused by the organism Cryptosporidium. It's a parasite. And, but in just this isn't just for this example, it happens a lot, is that people aren't sick enough to go to the doctor. So they might have like cryptosporidiosis, but they kind of resolve it on their own and they never go to the doctor, so we don't hear about them being sick. And, or like the whole household's sick, like 8 people are sick, but only 1 person gets the test, but everyone has the same symptoms. The doc just treats the whole family. It's kind of a cost-saving measure, which makes sense, but then when we get the numbers, it's not really 8, it's 1. So we get just a little picture of what's really out there. But in 2007, we started having, one of our epidemiologists says, man, I've had like 8 crypto cases in the last 2 weeks. That's a lot compared to what I normally see. We're like, huh. So we go back and look at his investigations, and we see water park, zero depth water park, and YMCA here. And then we're like, well, that could be a problem, but we're not sure. And then all of a sudden it's like, okay, more crypto cases. All right, there's something going on. So then we did like our public health emergency response group. We got, you know, our response group together, said, okay, there's something going on here. So we started going through our investigations. started going out to these sites that had kind of been named as possible sources of infection, and we took water samples from one zero depth water park, which you guys know what those are, right? It's kind of like this. It's kind of hard to see, but it's like flat ground, but then there's like water spraying out of the ground. So kids like to play in that. For example, this kid that was taken at one of these ones in Idaho is sitting in a dirty diaper probably, like right on top of one. And the problem with this park is that this water was getting recirculated. So it would go down into a system, and it would go through a filtration thing and come back up. Well, this is a city-owned park, so they didn't pay like the $10,000 extra to have the right purification system in. So it didn't take out the parasite. So this water is just recirculating that stuff in that diaper probably. And another bad thing was that the pipes were connected, and this was incorrect in the engineering piece, but were connected to the water fountain. So it wasn't just kids that were drinking the water, it was adults too. Because you know, adults don't usually play in these, but they were getting sick too. So, so this is just one example of what was a very big issue. We had, like I said, over 200 cases in the course of like 2 months. And it was because these water systems, and there were a couple that had been built in the same year, and then they would go over to like Roaring Springs and they'd still have like, be sick, and then Roaring Springs didn't have the right filtration system, so then it got into their water, and then YMCA goes over there, you know, people go and play in the water and they spread it there. So we had a lot of different pools and these places that didn't have the right filtration things, and luckily at this time summer was coming to an end, school was getting ready to start, and we worked with these facilities. They shut down for a while, and like this one, they got the right filtration system in, so now it's safe, you can go there. And Roaring Springs put in UV light. I mean, something as simple as UV light fixed the problem at the kid play part at Roaring Springs.
But that UV light costs $50,000.
Yeah.
So it's not a cheap fix.
No. Yeah. Yeah, well, that's why they didn't put them in to begin with, you know. It'll be fine. We'll take our odds. Take it to-
I think for UV light it's separate part.
Right. That's this part. This is where this is. Yeah. But you know what? They're lucky they didn't get sued. One lawsuit, and it would have been a lot more than $50,000 probably. No. That little thing down there at the Grove that you see like people ride their bicycles through and their dogs pee and stuff. Yeah. But we do check that.
Yeah.
And they are supposed to be, I don't think that's actually supposed to be recirculated anymore, but yeah, it was a problem, but I think they've fixed that. Yeah. And so this is like the parasite. That's what this is. It's like a worm. It lives in your body. Okay. I've got like 5 minutes. Let's see. I'm going to skip the whole flu one. You guys probably heard enough about that. This is what's going on today. I actually just got this email last week. Syphilis. You guys know what syphilis is? Sexually transmitted disease, gives you sores and rashes and stuff like that. You eventually die. Well, I would say you would eventually die from it, but there is treatment, and if you go without treatment, there is potential that you develop neuro disease. I don't know if that's a nickname for it, but it can be. Yes. Because not everybody has a rash. Not everybody sees the sore. For like females, it might be inside, and for guys who do certain sexual practices, it might be inside. So this is an investigation that we're currently working on where the red cases are people that have confirmed syphilis, and then these yellow people are people that who were identified by the red people as people they've had sex with in the last like 90 days. And then, and we don't know their status. So these people, all these yellow people could have syphilis, but we don't know. And then the white guys, like these over here, we've gotten them in, and we know they don't have syphilis. So, or they've been treated. So the issues with these are that some of these are people who we have syphilis is primarily in our population of men who just have sex with men, but some of these are men who have sex with both men and women, so it's kind of going both into the homo and heterosexual populations. And so it's pretty dangerous. This is like a lot more than I wouldn't say a lot, but it's certainly very concerning for us. And just like the crypto that I was talking about, we don't really have a full picture of what's happening because people don't, like she said, silent disease, a lot of people don't know they have it. So if they're connected to this group, they could be spreading it back and forth. And some of these you see, like we have like D3 here. Those are people that live in our neighboring health district. So obviously diseases cross borders. They're not just located in our county. They meet people everywhere. So I just wanted to show you that. This requires laboratory pieces and collaboration between neighboring health districts, and actually someone from our state EPI office put this nice diagram together for us. And investigation is really key to like preventing the further spread of this disease and making sure people get treated. So.
Great. Thank you.
Yep.